Well, hello, and thanks so much for joining me today for episode 2 of season 5 of the Healthy Skeptic MD podcast. I'm Dr. Michael Hochman. I want to begin again today by thanking and acknowledging the SCAN Group and SCAN Health Plan for generously funding the Healthy Skeptic MD podcast. So my guest today is Miss Jennie Chin Hansen. If you have done any work in the field of geriatric medicine, in aging, creative programs for older adults, you've almost certainly come across Jennie's name. She's the former president of AARP, former CEO of the American Geriatrics Society. She's won numerous awards. She's currently a board member of SCAN Health Plan, which is the funder of this podcast, also former board chair of the closely affiliated SCAN Foundation. But what I find most interesting about Jennie's resume is the 25 years she spent as a nurse working on creative programming on the front lines for older adults with the Onlook Foundation in San Francisco, a very creative group that, among other things, developed the PACE program for all-inclusive care for the elderly, which has become a national Medicare program. We'll talk a little bit about it in my discussion with her today. So stay tuned. It's a really good discussion, and I really get a chance to pick Jennie's brain about where things are headed in the field of aging and geriatric medicine in the years ahead. If you do find today's episode engaging, please do search and subscribe to the Healthy Skeptic MD wherever you listen to podcasts. Pass it on to others who might be interested. So without further ado, let's jump into our interview with Jennie Chin Hansen. Well, I'm very happy to have on the show today Jennie Chin Hansen. Welcome to the Healthy Skeptic MD.
Oh, Michael, thank you very much for having me.
So Jennie, you have had such an interesting career in healthcare. You've done so many different things. Could you, I'm not even going to try to describe it. Could you try to give us a 2-minute synopsis of your career path?
Sure. Thanks, Michael, for asking. Well, I was educated and trained initially as a nurse, and the thing and that's important because it's an interesting time when I trained, which was 50 years ago, and the role of nurses vis-a-vis physicians was established with a certain cultural framework. And so when I went into school and went through my training, I ended up feeling the disparity of regard and understanding of people's contributions. And that probably set my career path up quite early. I ended up being rather rebellious in the course of my education and came out okay, luckily. But one of the things, I didn't do things as prescribed when they didn't make sense. So I think a core theme that covers all my work is that I like to see things have common sense, and whether it's why a patient who was being cared for at a city hospital would have the horseshoe of doctors around him, talking about him as an object, was something that I found anathema because they were speaking about amputation, and this gentleman had never heard of it before until this crowd of doctors were talking about him as he lay in bed. Fast forward to the rest of my career, because of the hospital experience, I ironically felt that I didn't want to work in hospitals because of that structure. And I wanted to work in an environment that I could meet people where they were at. So I ended up going into community medicine, worked at one of the first ever community health centers that was established after President Johnson's work. Did work in academia, did work in public health in general in rural Idaho as well. And then finally, my core amount of work, even though I started to study clinically on adolescent health, I landed in the public health sector, but found myself gravitating to older populations. And besides the academic teaching that I was engaged in, I landed in San Francisco at a small not-for-profit company about caring for older individuals in a way that was about nursing home criteria for quality. In other words, people were frail but couldn't get into nursing homes. So it was a matter of that factor. So I spent most of my career in that model, developing and being a part of it and moving it to federal legislation. And I spent nearly 25 years there and then did different stints at AARP during the healthcare reform debate, as well as sat on the federal commission for Medicare. So from policy to advocacy to operations to education.
Well, I always have said or felt that nurses are my favorite type of healthcare change maker and leader. In a lot of ways, nurses are closer than any other healthcare professional to patients. They understand it from that perspective. And I've just really been impressed what nurses have been able to do in policy. They get it at a level that many others don't. Could you mention a little more about your work with Onlook in San Francisco and a PACE program? Our audience is mainly a lay audience. Maybe say a little bit about what a PACE program is.
Well, the program I somewhat alluded to, where I spent 25 years, is a program for older individuals, most in their 80s, who might be qualified to be in a nursing home. And so in those days, we're talking 40 years ago, we couldn't find beds in facilities that were open to people who were poor, who might be qualified for Medicaid or Medi-Cal, as we call it here in California. And so the idea of helping people stay in their communities rather than having them go to a facility or an institution was by default, rather than the fact that it was the first intentional. But when people did get a bed, say in a facility, it oftentimes was hours away from their home. So suddenly the food, the people they're familiar with, their language, all of that was lost. And so it became clear that rather than doing that, we had to think about a different way to support individuals. And we lucked upon a geriatrician from Oxford, England, who said, don't think about building a new nursing home. Do what we do in the UK, and that is have a day hospital where people come during the daytime for their clinical activities and treatments, but then they go home at night and sleep in their own beds. And when they're at the clinic, they can socialize a little bit. So that was the beginnings of a different way to think about people who might be much more impaired, but could actually still live at home. So that's the core of it. And we did it as a more social model initially. Needless to say, clinical medical issues evolved. We realized how crucial medical care was, good medical care. So we added medicine afterwards. It wasn't the first thing. So the order of that was, I think, very pivotal in the framework of a model of helping people live their lives in their homes and communities for as long as possible, rather than feeling that they all had to exit to an institution.
You mentioned before that you like programs that are based on common sense, and that's one of the things that always strikes me about PACE. It is sort of a radical version of common sense. Rather than paying for a nursing home, which is not the best situation for a patient, pay less money to keep them healthy in a community setting. And I think you're exactly right. The foundation of that is not necessarily medical care, but it's social services and other supports. And the medical care is sort of the top layer of it, but not the foundation. And PACE is now a national model that is a Medicare program that's done throughout the country. And you were at the forefront of that. Onlook was the first PACE program out there. Is that right?
That's correct. We were the prototype. We didn't know that at the time, but we were a grant testing program to see if something like this worked. And the formal process of meeting rigorous standards of research and outcomes allowed us to then receive some testing money from the Robert Wood Johnson Foundation, which is the largest healthcare-focused foundation in the country. And we tested it in 7 different communities all throughout the country. And was this an anomaly? Is this kind of a one-off rather than the fact that this could be done? We did prove over a number of years that it could be done, and it became passed as a federal law and changed the Medicare program to allow this to occur. So now there are about 30 of our 50 states that have PACE programs, and it continues to grow more rapidly now, especially as a result of the option being available during this pandemic, where it does actually center on staying in your home and community more than being in an institution. So I think its visibility has heightened in the more recent time.
Well, I've actually worked in two separate PACE programs. I spent 4 years as a physician in the Altamed Health Services PACE program here in Southern California, and I did my medical training at the Cambridge Health Alliance, which has an affiliated PACE program. And it is just unlike any other setting for providing patients. It's really holistic, and there's connections between the clinicians and the patients that are really unlike anything else I've seen in healthcare. And it's really amazing that you were part of the launch of that program at the ground level. You mentioned that the idea from this was in part motivated by a British physician. We do things differently in the United States than other countries in how we think about care for older adults. What do we get wrong, and what lessons do we have to learn from other countries in how we think about older adults?
Yeah, I think what we see from all these other developed countries like the United States, the way the country's policies direct their financing of care of older people is quite different from where we do it in the United States. We pay a lot more, or spend a lot more proportionally for clinical medical care, but we spend far less on social-based supportive care. And so I think that has been just so common for decades here. But more recently, and some of the work that we've done at the SCAN Foundation talks about rebalancing, realizing that the way the resources are allocated could be done differently. People who would like to stay at home, which I think studies by AARP and others have shown that most people would rather age in their homes, is more manifest, especially in the Scandinavian countries, even in Germany, where there are more funds directed for social-based care. So I think we can learn from that, and not surprisingly, that shift has been occurring over the past 10 to 15 years, where states who used to pay a lot of money for nursing home care, very little bit for social-based community services, are now doing what they are calling formally rebalancing the spending in that, so that we can build an infrastructure in the community to support people. So I think that's what we can learn from others. We have been learning, and I think it still is happening. And unfortunately, because of the focus of the rate of illness and deaths in nursing facilities over the pandemic, perhaps that's an added driver for us to understand it is possible for people to age in the community, but you do have to have services, and especially since the caregiver population is actually reducing. Many of the boomers did not have many children, so the proportion of caregivers has been reduced dramatically and will be reduced dramatically.
One of my favorite healthcare books is Atul Gawande's book, Being Mortal, and he talks about the culture in India for older aging family members. And in India, the idea of a nursing home is almost unthinkable. If you have a family member or a neighbor and they need help, of course they move in with you. And that's not something that can be legislated here in the United States. It's a cultural factor that's really baked into our culture. And I'm not saying there's a policy fix to it, but it just really is a very different dynamic here than in many other countries, how we think about aging. And we, for practical reasons, may need to think about it because, as you said, our population is aging and we just don't have the nursing home capacity, and it's just not the best way to do it across the board.
And your point's well taken. The one kind of added factor, as I already alluded to, is that the number of caregivers, family caregivers, just aren't available as they used to be, because there are fewer adult children for this, and many of the boomer women actually never married, and as a result don't necessarily have children as a natural network. So I think there's going to be some creativity of thinking, whether it's small group living or other ways to do it, but ways to do it so that people can feel secure and have companionship and have enough medical or clinical services when they need it, but not have that be the dominant factor of where your housing is.
Yeah, and I think the lesson from PACE is exactly the right one, that you build the community and the social services, and then you put the medical care on top rather than vice versa. So Jennie, you've recently become very interested in rethinking the way we provide acute emergency care for older adults. In the United States, the thing that our health system is very good at is providing aggressive interventions, cardiac catheterizations to open up blocked arteries, surgical procedures. But older adults, the situation is more nuanced. Older adults don't respond as well sometimes to aggressive therapies. It's sometimes a lot harder to tell if it really is an emergency or it's really a more subtle symptom. Could you just talk a little bit about emergency care in older adults and how it's different from younger individuals?
Well, I think our healthcare systems, our hospitals, are built to have these trauma caring centers for emergencies. And they have over time at some points become more primary care. And so given the fact that the way they are accredited and expected to operate is on a speed of quick assessment, addressing and a solution. And then perhaps a disposition might be that they can go home from there, or if needed, go into an inpatient bed. And so the emergency department has a particular culture and structure and cadence. And so sometimes when you have an older person who may have several medical conditions and they have some symptomatology and they show up, it takes some time to really sort this out. And then on top of that, many older adults may have some kind of memory loss or perhaps even a clinical condition with dementia. And that compounds it when somebody's on a number of medicines, have a number of conditions, find themselves so confused in this environment when they may have come from their home where they live with one other person or themselves, and that you think about that from a quiet personal space to the bright lights of an ED and the pace of the ED. That by itself is a major factor of disorientation, let alone what brought them there in the first place. And so EDs were really geared for trauma, car accidents, major traumas that occur. They really weren't geared for this sorting out time of what's truly going on with somebody who feels dizzy, or they have a stomach ache, or they're not breathing as well. And so the time factor just isn't synchronous with a person who has all this going on with a visit that in a matter of minutes, the ideal thing is to sort out what's happening and get them to the right point of treatment. So it was found that this actually became traumatizing enough that it caused a condition called delirium, as you well know, for older people, that suddenly they can quickly devolve into this added condition, which further compounds it and frankly puts the person's life at greater risk of not only illness but possible death. And so it was recognized by a emergency physician who happened to have a master's in business at the same time in New Jersey, and he could see this just wasn't fitting. So he designed the first ED, emergency department for geriatrics, and convinced his hospital in New Jersey to build a separate entrance for somebody to go through that door so that the cadence, the timing, the physical setting was different. And so what was so interesting and in some ways not surprising, people who ended up going to the ED at this hospital had heard about this geriatric ED, and they wanted to go through the door of the geriatric ED instead because it was calmer, people took their time, it was just different. So it's having a culture, processes, and a structure that allows people to take the case. It's like, rather than going to getting on the highway at 60 miles an hour right away, you have an on-ramp of gradually getting on so that people understand you. My husband ended up using a geriatric ED in New York, and the first thing they asked him, when was the last time you ate? And I was away on a trip, and so he was by himself. He had ended up with shingles, but he hadn't eaten all day. So one of the first things they made sure he had was a turkey sandwich. And he remembered that it just kind of calmed everything down, and they understood he was in pain. But they were concerned about his nourishment as well. So there are different things that were taken into consideration in a geriatric ED. The lighting, the cadence, the waiting area, all of this was dialed down versus the usual intensity of the ED, because that intensity sometimes creates a secondary set of issues for the person who's going in who's older.
Well, your husband's story contrasts very much with what I've seen, sadly, so often happen to older adults when they go to general emergency rooms. They might come in with, a significant issue like shingles, but as soon as they get there, the reactions start, and CAT scans start getting ordered, and dyes start getting administered, and antibiotics start to be given, and sometimes the treatment actually makes the condition worse. That overreaction. It's interesting. We've had pediatric emergency rooms and urgent cares. That idea, it's long been recognized that kids respond very differently from middle-aged adults to treatment, and it makes complete sense that the same would be true for older adults whose physiology is different.
Well, there are now about 250 emergency departments that have received certification now to become qualified, because a lot of places might advertise that they have a good geriatric focused emergency department, and sometimes, frankly, it's just the external features, that the lighting's nicer and is a bit calmer. But very key to this is having clinicians who understand older people who oftentimes have multiple medicines and are reacting to that. And on top of that, they're confused, or they live alone, haven't eaten for a couple of days. And, so having knowledge of the population, just as you were saying about pediatrics, there's knowledge about peds, that it's important to have that kind of competency so that the setting and the qualifications of the people match the population.
So when was that first New Jersey geriatric emergency room built?
I think it's been about 12 years now. And so a lot of, that realization became the stimulus to think about this much more. And what happened is 4 professional societies came together, the American College of Emergency Medicine, the Society of Academic Emergency Medicine, the Emergency Nurses Association, and the American Geriatrics Society, where I was CEO for 5 years. This work actually preceded even when I got there. So over a number of years, the 4 groups came together and developed the standards and the processes and ways of thinking about how to assure quality. When somebody says that they're a geriatric ED, that has to mean something, not from just a marketing perspective, but really from a performance and accountability perspective. So there are degrees of accreditation, just like there are degrees of that kind of accreditation of emergency departments, because your major big hospitals like our trauma centers, they're quotes level 1, which is the highest sophisticated level. They did that for the geriatric qualifications as well. So increasingly, the states like New York has actually the governor has said that by, I think about 3 years from now, that 50% of the hospitals were going to be certified for geriatric EDs. So other states are beginning to look at that as well, just because, frankly, our population is aging, and as a result, even the hospital beds are anywhere from 40 to 50% older people.
And you said there's about 250 to 300 around the nation now, or are these in a mix of states?
Yes, they're scattered all over. I would say in New York, Northwell Health System, that's one of the biggest systems in New York City, has all of its emergency departments actually qualified now. And the Veterans Administration has committed to developing 70 within the next couple of years. So there are different larger systems that are taking this on, both in different states, but on system level as well. And
if you live in a community, is there a way that you could check to see if there is a nearby certified geriatric emergency room?
Yes, I think that if you go to the website for the American College of Emergency Physicians, that's ACEP, they have a section that describes geriatric EDs that are accredited by them.
And I can put that up on my website in case anybody wants to check that out. Now, it's not just emergency departments per se that are the problem. Paramedics, for example, EMS programs that go out to the field sometimes aren't, don't react the appropriate way for older adults. And so you've also been doing a little bit of work in this area, rethinking how paramedics and EMS responds to older adults. Can you say a few words about that?
Sure. I mean, this is a developing area. It's not well developed yet. I think those who are living in rural areas realize how difficult it is sometimes to get emergency response systems to work as effectively just because of the location and the distances. So I think by default and need, some places have developed what they call community paramedicine. So in other words, some of the EMS workers who are trained in addition to be able to screen more effectively and perhaps treat people in their homes rather than having to transport them. And so this is still novel because there are rules and regulations and there isn't the strong infrastructure yet. But over time, I think that will develop and, is it possible? It's not just having access to it. The question is sometimes, do you really need to go to the ED? And it may well be that you have an urgent issue, but you need somebody who's skilled to be there to make a quick judgment as to whether or not you really need that. But if there's something that could be done while they're in the home and they have some equipment with them, that they could be using televideo support to do this. So I think we're going to try to take advantage of the greater telehealth system, just the reality of access, and the common senseness point for me again is, does it make sense to transport somebody 30 miles in order to find out that this perhaps could have been treated easily at home? So it's less traumatizing for the individual, and there's less use of resources that might be used differently, and the cost is much lower.
Well, I think you highlighted the key question, is it necessary? Because once the decision is made to bring someone to an emergency room, the reactions and the cascade starts to happen, and there's almost no going back. So there's such an opportunity. And I think paramedicine has an incredible potential. I've been doing homeless healthcare, as you know, Jennie, and for patients with substance use disorders, someone who's intoxicated, for example, the right answer in many cases is not to rush them to an emergency room. It's just to find a safe place where they can detox in a safe environment, and an emergency room is not that. And I think for older adults, there's tremendous possibilities. So I really hope these paramedicine programs get empowered, because there are some laws in place where people have to bring you to the emergency room, and that's just the opposite of common sense.
Exactly. I think at least, there's some change in policy that allows for payment of paramedics who treat somebody and don't have to bring them to the ED. So it tells us, that the common sense sometimes gets distorted because of the way things get paid. In most places, to your point, unless that ambulance takes the person into the emergency department, they don't get paid for that trip, by many factors. Whereas the ability to do the treatment and do this in, 15 minutes and have the person stay stable, safe, and not be, driven hither and yon into this, wild and woolly west of the ED, doesn't make sense. And or if somebody has dementia, which is the area that we're working on in particular here in San Francisco, is to see, are there ways that the family member could be prepared better for the handling some of the behaviors that happen? Because sometimes it's because things have spiraled, and the only thing you can think of is having your loved one go to someplace else where they can get help. So we need to do a lot more on what I call primary and secondary prevention, so that the person may not need to go there.
And Jennie, you also mentioned that you've done some work on certified nurses who can help with triage. Could you just say a word or two about that as well?
Well, I would say that's more in the making. I've always felt that community workers and nurses' aides know the patient the best, even more so oftentimes than nurses might do. And certainly since the doctors don't see them that often even there. So the ability to have the person who's closest and spends the most time with the person who's being cared for us to really both listen carefully, hear them for what their observations are, as well as provide the kind of training that gives them the skill to really pick up on certain things that are variances that need attention. So I'm a real big proponent of supporting that workforce, and as well as seeing that they get paid well for that, and that there's a career ladder for people. In where I worked at Onlook in the original PACE program, we had ladders for people to move up, and we had aides who eventually went on to become licensed vocational nurses and registered nurses. So one, that they're well supported, their payment is more than a livable wage, and they're in an environment where they are regarded and respected and can share their knowledge and add their skills to the care of the individual, but could see that they're part of a team and they're not just doing transactional care.
Well, as an aside about the workforce issue, again, the homeless healthcare experience I've been having, we've been working with peer navigators, and the market rate is minimum wage, $15 an hour in LA County. And in a city like LA, it's just so hard to imagine how somebody, I'm embarrassed to say, lives on the minimum wage. And, so I think it is so important to create a pathway so that people can get a little more comfortable as they grow in their careers and, expand their skills to a new level.
Yeah, I think it's also recognizing this is economic development. This is creating jobs that pay for your skill, respect the skill that you offer, and see that there's there's opportunity for movement if, so desired and the person has skills to do this, rather than the fact that this is a siloed job. So I think, this is a culture change that is significant. And I think, we ignore it at our own danger that we don't do this because it's easier to get a job at a fast food place and get paid equal, if not more. I mean, we have to make sure that people are rewarded and recognized for the skill and the care that they bring.
Yep, that's right. All of us respond to incentives, and if we want to incentivize the growth of the certain industries, we have to incentivize what we want, and there's a real opportunity there. So Jennie, let me play devil's advocate a little bit with you. One of the concerns with paramedicine and trying to triage things in the community is that we may miss serious medical conditions that, for example, heart attacks can be very subtle in older adults. Are you concerned or worried that if we try to do too much in the field outside of emergency rooms that patients may get sick because we don't act fast enough?
Well, of course, it's always on the ends. Either we get them into a place that overtreats, and then your comment about asking about how do we not miss critical aspects. So I think that, yes, that is always a risk. But I must say that an area of wearable technologies now that are possible for people with some areas of chronic disease can pick up on subtleties. If we set what their baseline is and know that they have variance that sometimes will not be visible, but it actually probably is measurable. And so the ability to use tools that may be available to us when we know people have certain kinds of conditions that could be very hidden, but are there technologies that might help do this? We've heard often, I think, as the public, that people who wear Apple Watches individuals have been saved by some of the facts of what their heart measurements have been picked up elsewhere, and somebody has actually intervened. So I think we take advantage of some of the advances in technology now with things that we know can be more subtle. And we also need to know what people's baselines are, because sometimes we have these norms of what a poor reading is, but maybe that's what that person's baseline. That's one of the things in PACE I always loved. We could understand what your normal variance was. And so when we know what your normal is and we get another reading that looks like that, we know that's your normal. But somebody, cold coming in seeing, and that's a measure that in other people would be important to treat. We don't overtreat somebody when we know this is your normal. But I think we have technology now that is able to, check in with that in ways that we didn't have before. It's not nirvana, but the question is overtreatment versus undertreatment.
Yep, and I think we probably cause as much or more harm from overtreatment as we do from undertreatment now. So I do think we need to shift the balance a little bit. The only thing I would say to those safeguards is, I think patients' family members can be incredibly useful in terms of knowing what their baseline is. And because of the way paramedics are paid, they don't get paid to make a phone call to the patient's daughter or son to say, is this really out of the range for your mom? So I think, using those safeguards and those tools, there's a way to get this balance right.
If I could add one thought to that, and that is, I think it's important to have your own health history available to close by, so something that's visible. We used to have what's called the vial of life in the days that I used to be in Idaho, that we would have in their refrigerator. If a paramedic showed up, they'd look in the refrigerator and there's this little medical record that we had put in a tube. So I think having your own baseline, because what happens is somebody sees you for the first time cold, you're in distress, it's hard to get accurate information. But if you have your healthcare summary in a way that's accessible, so that it's picked up in an emergency, that somebody can get a good baseline. That's again a common sense way to think about certain things that are helpful for anybody living at home with many conditions.
Yeah, and I think there's a tech innovation waiting to happen there. In the year 2021, it just always seems amazing to me that there's not a way that you can pull up someone's health records. We have all these regulations in place that make it very hard to share data. So hopefully that's going to be something that's going to improve over the years with some policy changes. So, Jennie, the final couple questions I have for you relate to your work with SCAN, the SCAN group. You are the chair of the board of the SCAN Foundation, and you're on the board of SCAN Health Plan. And of course, I am a physician within the SCAN company leading the Healthcare in Action group for homeless patients. I'd love to hear about how the SCAN organization has been doing work to address some of these challenges that you've alluded to and improve care for older adults. Could you talk a little bit about that?
When I start with the health plan that you and I both belong to, I've had a chance to be a board member of this not-for-profit health plan, and we have about 220,000 Medicare beneficiaries. The idea of understanding what that journey is for an older adult who signs up with a health plan, especially today, we're right in the middle of what they call open enrollment, and all the ads on the TV are talking about all these benefits. But choosing a program that will certainly pay attention to the doctors you get to choose, as well as the medicines that you take, are they on the list? So I'm really proud that part of our culture and our values at the health plan are understanding where people are at and how can their life be made easier and better. And so designing it so that it makes it more simplified. The pandemic showed how difficult that could be. A great example is when somebody comes in, an older person who's on many meds, we can see that they would get somebody to coach them and help them learn how to order online or call it in so that they don't have to go to the pharmacy, making life easy. Because for older people, now that technology is available, sometimes that's pretty scary. So our health plan introduction includes understanding, who your doctors are, who your specialists are, and as well as if you're not ordering medicines remotely now, step by step, walking you through, hand-holding you through the process of learning how to do this. So the sense of understanding that. And then for during this vaccine period of time when people wanted to get the vaccine for COVID, but were homebound, our health plan actually arranged with an emergency transport system to have their medics provide the immunization. So I'm really proud that our health plan cares about your total well-being, your clinical care, but really, how does it make it possible for you to keep your health and access help differently? So that's part of the health plan. And we're doing innovations like your work with our homeless older adults and other projects that are, again, how do we make people's lives function easier, better, and in a way that they can both save money and live their lives.
And I'll just say one additional comment about the health plan. I think it's fair to say that SCAN Health Plan is very different from a lot of other plans in terms of its roots. It really was a community organization that became a health plan. It's not a big corporation. It doesn't have that same feel to it. It is nonprofit, and as you said, I think that really is evident in the sort of perspective way it approaches health and preventative care. So it really has a very different feel than many other health plans do.
Thanks for bringing that up. This was actually, this plan was started by 12 seniors by themselves. They wanted something that made sense to them. And we've carried out that culture throughout the time. And something I failed to say, which I should say with this opportunity, we are a plan that has reached a star rating that's 4.5 stars out of 5 stars, which is almost unattainable for 5 years straight, which is, I think, not achieved by anybody else thus far. So again, the idea that when you call, we have a call system that people will remember your background and have a chance to make sure you get to the area of need that you have.
And the foundation is a separate arm from the health plan, but they're all part of the SCAN group organization, if I said that correctly, Jennie.
That is correct. Thank you. Yeah, the foundation was actually funded by a gift from the health plan about 13 years ago. And this is a foundation that really focuses on older adults, but older adults that especially are managing complexity. And so some of the funding has gone to programs and issues that affect everybody. So this is not a SCAN only. This is really for the public good. So everybody has access to this. So a few areas that I think that we're especially proud about, since we talked about community-based services, we were the first foundation to focus on thinking about what's happening across the country right now. With services in the community relative to services in nursing homes. Many, at the time that we started this work about 10 years ago, we saw that some states were probably 70%, if not higher, nursing home, and only, say, 20 or 30% funds going to developing these community services that help support people. So we've done a mapping process, and we're in our 4th publication to show what has happened to shift this so that we're ready in the community. And certain states that have gone and won an award for the most change. And this is a tool that we use throughout the country with AARP doing some of this research. And in California, we use that as a guideline as to what the proportion of what I talked about other countries having good community services. So that's one big thing. The state now has a master plan for aging, the first one in California that has ever been developed. And the SCAN Foundation has been a primary encourager of this work for the probably at least 9, if not 10 years. And now, along with 6 other foundations throughout California, we have funded this effort, and the state and the governor have launched this as of January this year, 2021. And so there's a whole program of thinking about what are the big issues that we need to face as a state and having a plan for aging, not about the aged, but for aging. So it's intergenerational, as well as thinking about housing, to clinical care, to safe parks and activity, your income, because that's very critical for older adults. So those are 2, say, big areas, and we do more. And hopefully you can put the website on the link for people who are interested.
I'll absolutely do that. And the only thing I'll add to that is, although SCAN Foundation is primarily based in California, it is a big player in the national policy stage. So if you talk to federal legislators and policymakers about older adult policy, the SCAN Foundation always comes up as one of the most impactful organizations. So really it has a disproportionate impact based on its side. And I'll just give a shout out to Dr. Sachin Jain, who's the CEO of SCAN Group and SCAN Health Plan, and Dr. Sarita Mohanty, who leads the SCAN Foundation.
Thank you so much for bringing up the policy. I can't believe I didn't bring that up. But the thing that some of the health plans nationally are now offering some community type of services, like just transportation and meals and all. And the legislation that was enabled to make that is called the Chronic Care Act. And the SCAN Foundation was very pivotal in working in D.C. with colleagues to help raise the impact of this, the reason for it, the research behind it. So the fact that we're there, and we're also in Sacramento with some of the work of the master plan. But the policy area is one that we try to work in, and especially thinking about how do we pay for long-term care in the future. We've been the only foundation in the beginning to really emphasize and elevate this issue. But this is a powerful and unsettled area as to how we'll pay for care that we'll need when we're more frail, and Medicare doesn't pay for this.
Yep, I think and SCAN has done a really important job advancing that thinking process. And also I'll mention during the pandemic, thinking about some of the challenges that we've experienced with nursing homes and COVID outbreaks, SCAN has really been at the table thinking about how to remedy some of those challenges. Well, Jennie, I so appreciate your joining today. A great discussion. You've such an interesting and truly multifaceted career, all the various different things you've done. So thanks so much for joining me today. If you do enjoy what you heard today, please do search and subscribe to the Healthy Skeptic MD wherever you listen to podcasts, and we'll pick it up again in a couple of weeks. Thanks again for joining me.